So we're going to hear now from Dr. Yangmin Zeng about PD growth in Fraser Health. Welcome.
All right, we'll get started. Good morning, everyone. Thanks for having me here. I'm quite excited to be here to share some of the work we've been doing in Fraser Health. So, no disclosures. We'll start off with a live poll question. So as many of you folks know here, PD and HD, if you get, are the modalities that are available to people if you don't get a transplant, and they have comparable clinical outcomes. However, PD in Canada and many other countries have a cost advantage over in-center HD. So how much cheaper approximately is PD compared to HD in dollars per patient per year? And this is in Canadian dollars. So those are the choices. All right, so that is right. 20 to 40,000 is the most reflective. Can we go back to the slides, please? Thank you. So this data has been compiled in 2009, so this is a little bit older. So when you look at the ratio of HD to PD costs in Canada, HD costs almost twice as much as PD. In BC and in many jurisdictions, PD is practiced as the favored approach. However, despite the movement in the last several years, HD is still the majority of cases for initial modality for our patients at 75%. So to move on to the Fraser, we have to look at the geography to put things in context. So the Fraser serves from Burnaby all the way up to Hope. We are, I believe, the largest health authority. And when you look at the green part there, those are the Fraser North communities. The purple are the Fraser South communities, which are comprised of Delta, Surrey, Langley, and White Rock. And in the east, we have Abbotsford serving from Mission all the way to Hope. So if you look at the population, and something that's unique in the last several years, the population growth in the south has been tremendous. And now Fraser South comprises almost half of all Fraser Health Authority population. The only two PD units that we have currently available are in Royal Columbian Hospital and in Abbotsford, serving the region. And typically, people in the Fraser South would have to travel to the Fraser North and cross the bridges to get the PD services. And we know historically that in the South, PD uptake has been quite much lower and lags behind the rest of the Fraser, as seen here. So why is that? And we had to think about what are the barriers to PD in the South population? Is it the demographics? Is it clinician preferences? And those may be definitely contributors. However, there's possibility that access may be hampered by geography and logistics, not having any PD presence in the South and having patients needing to travel further out. So we established the Interim Fraser South PD unit to test this hypothesis. And that was opened in August of last year. And the intent of it was to increase PD uptake. So not just opening a unit, but also looking at ourselves and clinicians and going through systematically at how to optimize PD uptake. So we look at the steps of how someone gets on PD, and we, at all levels, try to improve it, such as identifying all existing prevalent HD patients and offering PD to those eligible patients, and streamlining PD orientation. And one of the exciting things that we've been doing is establish an urgent PD program in the South. And this takes a lot of work. And one of the in part is the nursing staff, but also having nephrologists being able to insert bedside PD catheters on very short notice. So while we started this program, we wanted to make sure we capture some data and to evaluate it. Specifically, looked at PD incidence rates, also the safety and quality of our program. And one of the unique aspects is that we looked at patient satisfaction. So we got feedback from patients. And the whole idea of this evaluation was to make sure that we inform our own health authority decision makers into whether we should be investing a full PD unit in the South. So briefly, the methods. We looked at 6 months baseline and calculated PD incidence rates and compared it to around 11 months period of study period and looked at incidence rates afterwards. And the primary objective is looking at PD incidence. We also monitored several other secondary objectives, such as peritonitis rates, PD survival, catheter function rates. And the satisfaction surveys were developed, 15 items, and it was validated and piloted on our patients prior to being distributed. So here are some of the results. We've got, in the 6 months period, we had 22 at baseline catheter insertions. And in the study period, we had 50 just in the south. And the age of the patients that we started on PD was 61. They were quite young. And the GFR at PD catheter insertions around 9.6. We also captured north data as well to make sure that we are not missing anything, any other trends. So on the left-hand side, you'll see the bars. So you have PD incidence of all dialysis patients, of all comers. So at baseline in the south, it was 25% in the 6-month period. And we saw an increase to 33% in the study period. In the north, we also saw an increase as well, from 27 to 39%. And we were wondering why we had an increase in both the south and the north if the south was being established. We don't really know exactly for sure, but one of the hypotheses is potentially we offload the north volumes, and now the north is able to accommodate more patients. Also, the clinicians in our division have been pushing more PD in the last 11 months. And we look at the patients' incidence rates from KCC, we also saw a similar increase. So that was quite encouraging. When we looked at the prevalence rates of PD in the same time period, in the bottom, you see Fraser South, and we see from August till June, which is the study period, there's been a steady increase in the prevalence rates of PD. In the north, there's also a slight increase in the end, and the east, which was unfortunately not part of this project, did not have much change. Some of the highlights of the secondary objectives, one of the things we noticed is that we looked at how many of our PD starts were urgent PD starts, so acute starts requiring intermittent PD, IPD, and around a quarter of those were, which is a significant proportion. And most of those patients who needed acute starts actually were known to nephrologists and followed in the kidney care clinic. We looked at the PD bedside catheter malfunction rates. It was comparable to literature, around 14%. Most of these catheters worked after a second attempt or manipulation. We had a couple of leaks. And peritonitis rates were captured, and there's a short follow-up time, so it was quite low. So when you look at patients who actually get a PD catheter, not everybody actually ends up on PD successfully. There's many reasons. The biggest reason, and reporting literature, and we found, was actually patients unable to do PD. Or their caregivers either back out or are unable to be trained as well. So that was one of the primary things we found, and a minority of other reasons, such as catheter malfunction rates. Just to briefly highlight some of the patient satisfaction survey results we got, 18 out of 43 surveys were returned. We looked at multiple dimensions like pre-dialysis care quality, overall quality of care, PD catheter insertion experience, et cetera. And most of the patients were quite satisfied with the program. We specifically asked 2 questions. One was, does having the PD unit closer to home matter when you were deciding between PD and HD? And many patients echoed that and saying yes. And we also asked this another way. How important was having a PD unit located in Surrey in your decision to pursue PD? And many patients said that was important. And in the comment sections, many patients wrote out why they thought the PD should be in the south. So far, we have some early data, no statistical significance, of course, but we've shown an increase in uptake in South from this program, and it's still early so far, so we have to see the long-term sustainability of all this. We've shown that patients were quite satisfied with this project, and they found it valuable to have a PD service closer to their residential homes. We saw a low peritonitis rate. We saw PD catheter acceptable functional rates. I didn't show PD technique survival, it's too short to really know, but it was quite comparable to that in literature as well. To highlight, though, is that we did all of this in very limited resources. We've essentially had one PCC for PD for 6 months and added a second one after 6 months. And we essentially found whatever space we had available, which is a procedure room in the HD units we used, all the hallway for HD for IPD, and a family room with 2 beds, which is not much bigger than a closet. So not much resources, but a lot of PD patients flowing through. So we had some recommendations at the end of all of this. One is we pushed quite hard in our health authority to invest in a PD unit where patients can actually have some space and our staff can see patients in follow-up clinics. And one of the other things that came out of it is that we need to work on timely PD initiation because urgent PD starts are a great potential to grow PD. However, it's quite labor intensive. And when you have someone acutely starting on PD, it really backs up the training of routine patients. And ideally, if you know a patient who, from the KCC, most patients should be started actually routinely, not urgently. So we need to work on that, whether it's clinicians at all levels. And one of the things that the Renal Agency has proposed is maybe we should be starting catheter insertions at GFR 10 a little bit higher. And we believe that in the South. And potentially there's opportunities to graduate a PD as well. Now, also, an important aspect of this data was that we need to also work on how to identify patients who are able to actually do PD. So there's a lot of wasted effort and resources to try to get someone a catheter and then not do PD in the end, and then having to transition modalities. And we'll, of course, do more data collection. So quickly acknowledge some of our staff. We have Sue Bao and Linda. Sue's in the audience, I know, and she's probably blushing. But this is our 50th patient. We had a small cake to just celebrate that. And we want to thank the rest of the team. Thanks.
It's a nice theme today for chocolate as a reward. One of my favorites. Any questions for Dr. Zeng? Thoughts or comments? It's impressive to hear how your program has grown, and I'm wondering, have you got proper physical space now for your program?
I'm happy to say that we are in the talks of getting some space. We're making the hemodialysis weight room area into a PD unit and kicking the patients out of the hemodialysis weight room area into the main hospital lounge. So I'm hopeful that will be sufficient space, but yeah.
No submitted questions. I have one more.
Oh.
Probably you're not going to surprise me with your answer, but you had patients write out why they wanted the services available closer.
Yeah.
Was there anything that came up surprising?
Yeah, not really. A lot of patients said that it was very hard for them to travel to the Royal Columbian from, say, Surrey or White Rock, and with the traffic congestion, and most of our patients sometimes were more frail, that it was challenging, and they would rather follow up in Surrey.
Right.
Yeah.
Yeah, that's great. Team structure is so important. I think we hear that again and again with these enhancing patients onto the independent modalities. Thank you.
Thank you.
I'd like to welcome Dr. Doug Matsell now from BC Children's. And he's going to speak to us on regional care initiatives. Dr. Matsell.
Well, good morning, everyone. And thank you, Carolyn, for chairing the session. And thanks to the PRA and BCKD Days for putting on a fantastic meeting again. And Stephanie, this is directed at you, of course. Good work. I also would like to thank Dr. Janice Dion, who is our pediatric medical director. And by the way, a shout out to the pediatrics group. I don't really know where you are this morning. I'm stuck over in the corner here. Good, great, good to see you this morning. And I wanted to thank Janice for allowing me the opportunity to speak to the Pediatric Nephrology Regional Care Initiative here in British Columbia. As I've sat through the presentations this morning, I was a little bit worried this might not fit in, but I actually think it fits in perfectly. So the objectives of the next few minutes, I want to discuss, as you've heard from the other speakers, we face the same challenges in providing regional care throughout the province, and you'll hear a little bit about that. It's a little bit exaggerated for other reasons in pediatrics. I want to present some of the progress that we've done. We have some pilot data to show you, and I want to introduce our future plans, where we're going to go with this regional care initiative. So, as you've heard, our program truly is a provincial program. And we have a mandate to deliver care to every child across the province. We're full service, so if a child in Prince Rupert needs a transplant, we have to be able to provide that for them, all the way down to outpatient consultations. But the guiding principles for regional care for our program is ultimately to try to deliver care to closer to home. And in doing so, the care that we deliver has to be equitable, regardless of where the patients are in the province. And what that means is someone in Prince George shouldn't be getting a different kind of care than they would get if they had come to Vancouver. Then the last piece, this is just a little plug, another guiding principle for this is that this type of care needs to be supported by the region and the health authority. So challenges, geographic area for sure, the childhood population density, and the limitations put upon us by the resources that we have. So you may or may not know, but there are approximately 1 million children in British Columbia. And this represents an area greater than the United Kingdom, who has 10 million children in the same geographic area. So this speaks to the challenge of childhood population density. Another way of looking at it, we have about 5 nephrologists, pediatric nephrologists in British Columbia to cover an area of 1 million square kilometers. So that, quick math, that's about 200,000 square kilometers. I missed a zero there, I see, per nephrologist. So we have taken the first steps, challenges notwithstanding. We first set out to define the level of care that we wanted to deliver across the province. You'll hear about that in a second. We also needed to identify which potential sites we would deliver this care. We needed to develop a business model, and then we needed to assemble a regional care team. So you may or may not know about the paradigm of tiers of service for regional care in pediatrics. This is an initiative that's been championed by Child Health BC across the province. And just in a nutshell, different types of care are different tiers. So if you look at the bottom of the pyramid, tier 1, represented in green, represents care such as preventative care. The most resource intensive is the top of the pyramid, tier 6, which is represented by blue, which represents provincial subspecialty service care. So this is things like in-center hemodialysis, transplantation. I'm speaking about pediatric care now. So the idea is that you're not going to probably deliver tier 6 and tier 5 care in a smaller community. And the flip side of that is maybe not necessarily that we need to be doing preventative care or tier 1 care. Not that it's not important, but that may not be our focus here in Vancouver, where we're a tertiary quaternary center. So I just want to quickly give you a profile of what we do in Vancouver. In Vancouver, being a tier 5, tier 6 center, we have about a third of what we do is CKD, transplant, and dialysis. A closer look at really what we're doing. So these slides that are coming up on the x-axis are the number of annual clinic visits. So this is outpatient care, by the way. On the y-axis is the type of care that we're delivering. I've put a tier 6, tier 5, tier 4, tier 3 on the right-hand side, and I've color-coded the bars according to tier. So blue is tier 6, orange is tier 5, red is tier 4. And you can see in Vancouver, we do a lot of tier 6 care, probably as much tier 5 care, which includes taking care of kids with nephrotic syndrome, glomerulonephritis, hypertension, and a little bit of tier 4, which we may or may not should be doing. Things like doing consultations for hematuria, hydronephrosis, and the like. So this data was provided to me by Child Health BC. It's actually really quite interesting. What it's looking at is historically, where do our patients come from that we see in Vancouver? So on the y-axis are the number of visits per 10,000 population. So it's weighted and standardized according to population and health region. On the x-axis is the health region. So you see it's broken down by interior, Fraser, Vancouver coastal, island, and northern, with the BC total on the right. And you can see that Fraser is our big user. And in fact, not only our big user, but proportionally we see more patients from Fraser. So there's a spike in the Fraser Health Authority, and there's a spike also in the Northern Health Authority. So either it's been a combination of maybe good planning and good luck. These are actually the first 2 sites that we've set out to pilot our regional care. So this is our facility in Prince George. On the left-hand side is the clinic reception area. It's beautiful, beautiful facilities. The examining rooms are adjacent to the reception area. And if you turn the camera around, you can actually get a shot of, that's the inpatient pediatric ward in Prince George, which is a really critical adjacency. So if you have a patient who's sick in the clinic, you can actually have that patient admitted immediately to the ward, which enables higher intensity care in the clinic, if you catch my drift. So, so Prince George, we see, Prince George Clinic has actually been there for a while, but if you look over the past 2 years, we're seeing anywhere from about 70 to 100 visits per year, with a healthy increase over the past year. And I thought I would break down the complexion of what the types of things that we're seeing there, and I was actually quite surprised. If you look at this, we're seeing predominantly Tier 5 care in the Prince George Clinic, with a little bit of outpatient follow-up transplant and CKD care, and very little low-resource Tier 4 care, which was a bit of a surprise to me. Now, switching to the Fraser Health, this is our clinic at Surrey Memorial. On the left is the reception area. On the right is an example of our patient examination room, with all the nice pictures on the wall. And if you look at the patient activity in that clinic, we opened it up in November of 2015. So on the x-axis are the monthly clinic visits, or the months, and on the y-axis are the number of clinic visits per month. And you can see, again, like in the Prince George Clinic, a healthy increase over the past 2 years. And in fact, this year, and this is not prorated data, but we're still not at November, we already have seen a more than 50% increase in the number of kids that we're seeing at that clinic. The complexion of that patient population is slightly different, and again, this is a bit of a surprise. We're seeing very little Tier 6 care. There's a little bit of CKD outpatient care, mostly Tier 5 care, with a healthy dose of Tier 4, less resource-intensive care, consultations for things like hydronephrosis, reflux, hematuria. So we had to assemble a team, and I should say that each team has a pediatric nephrologist. The nephrologist is paid through our divisional FTE. This is in addition to what we already have. We have a specialty nurse, a renal dietitian, a booking clerk, all of whom are funded through Child Health BC. And we also bring trainees with us to our regional clinics as a learning experience. On the right-hand side, this is actually a picture from last week up in Prince George. And we have our pediatric medical director, Dr. Dion, holding court with her blood pressure machine. And there's Dr. Salsan Al-Batati right beside her, who's one of our fellows. And that's Kirsten McFadden, our dietitian in the front. Which leads me into, so what kinds of things do the other people do in clinics? And Kristen provided me with some data over the past 2 years, looking at the nature, the complexion of our renal dietitian care. This is not just simply going in and taking a history. This is where she's actually dealing with 2/3 to 3/4 of what she does is high-intensity care, dealing with kids with nephrotic syndrome, hypertension, CKD. And the complexion of that care is quite similar from the Surrey Memorial and Prince George clinics. So the punchline here is, so this is what it looked like. This is what it looks like without a regional clinic. These are all visits from the regions that come here to British Columbia Children's Hospital. If we superimpose our regional clinics on top of that, you can see the impact that we're starting to make on delivering care closer to home. So that's the good news. The bad news is there's a couple of areas in there that aren't very well served, and that's the interior and Vancouver Island for various reasons. So as future prospects, we have every reason and every intention of expanding to the interior. And in fact, we have a pediatric nephrologist who lives in the Kelowna-Vernon area who's very keen on actually establishing a regional clinic with the support of BC Children's Hospital regional clinic team. We have shown you an evaluation. The evaluation to this point is just how much we're doing, the type of work that we're providing. I haven't told you anything about the quality of care that we're providing. We're getting there. People generally are happy that we're up there. The pediatricians are glad that we're coming into their communities. But we're going to try to quantify that a little bit better. And there's also a real opportunity here for clinical research projects. One in particular, as I was going over the slide last night, would be we're in the process of developing standardized care plans, standardized clinical pathways for care here in Vancouver. It would be interesting to apply those pathways to our regional clinics to see whether or not we're getting the same kind of outcomes. So that's on the horizon. I want to acknowledge a few people. Kathleen Gray, who is our specialty clinic nurse, renal nurse. She's sitting there at the computer on the right-hand side. She's not here today because she's actually at the Surrey Clinic, if you can believe that. She's the engine of our regional clinic initiative. Kirsten McFadden is our renal dietitian, and I think Kirsten's also in the clinic. We have an outreach clerk. Michelle Fryer is our liaison with Child Health BC, who's helped us negotiate and advocate for resources for our allied health team. And I thought I'd show a picture of Dr. Rob Humphreys, who's one of our pediatric nephrologists, who's done the bulk of the work at the Surrey Memorial Hospital Clinic. So I think I'll end there, and thank you for your time.
Any questions for Dr. Matsell? Great, yes. Finally, someone at the microphone.
Thank you very much for that, Doug. What's your sense in terms of the Fraser Health? Is it population? Is it a different disease? Is it a different demography of the population that we're seeing, new immigrants? Do you have a sense of what's going on?
I think it's just, in terms of the density of proportion of referrals, most of our patients, actually, now that we look at our demographics, come from the Fraser Health. And I think that it's overrepresented in some of the Tier 4 care that we deliver in terms of nephrotic syndrome, and it may have to do with ethnicity. But again, it's a great question to ask, and again, would be a great research project to try to dissect. But from first blush, not a lot different. Most of our patients come from that region, but we do see an awful lot of glomerulonephritis and nephrotic syndrome from that community.
Another question submitted here electronically. Is there a social work in the pediatric program?
Really good question. We have 2 or 3 social workers associated with our program in Vancouver. And for those of you who run programs, the dance here is to provide as much care as we can without endangering the program that we have here in Vancouver. So we don't have a social worker in our regional program, but it's on the list of things to do. And we're advocating for that, and we're looking for the resources to support it. And I think it would be at least a full-time position. So if you're looking for a job.
Watch for that posting.
That's a good question.
Thank you so much.
Okay, thank you, sir.